So first thing we began to do is we began to be educated, learn about Six Sigma. The MediSync team went out. We have a couple black belts, green belts, and then many of you will remember how we actually started Six Sigma. We actually took 2 hours off in the morning. We came into this room and we actually got on our hands and knees and we shot rubber bands across the floor. And then we're like, okay, we're cardiologists, we're endocrinologists, rheumatologists, pediatricians, family docs. What are we doing on our hands and knees shooting rubber bands? Very quickly, we realized, wow, if you follow some of the basic tenets of Six Sigma, we can get really, really good at shooting these rubber bands. So we're actually able to figure out, okay, now how do we move forward with that particular area? So that was really our very first introduction, was sitting on the floor and beginning to do that. Some of the tenets of quality theory is process, process, process. You've heard this a million times. You've done it a million times. And so as we begin our first particular spot, which was in hypertension, we decided this is going to be our big one. But remember, we're not a one-trick pony. We're going to use hypertension today to kind of go through this, but we've done this now in diabetes and in pediatric asthma. We got some great results and a couple other things likewise. But I'll keep going through hypertension as the easy one to kind of demonstrate. So if you can't measure it, we have no idea where we are. We got to measure it, and then at that point in time we can begin to look at, well, how do we begin to improve it? So the first thing we do is measure, process, process. Process is designed as basically having a very specific goal and then having some very specific steps to follow to actually hit that goal. So once we know that particular piece, we use Six Sigma. We establish our baseline performance, and you've seen the group numbers all the way through, but here's our very beginning spot. So we're starting at 40% as we begin to adopt these, the theory, the processes, the measurements. And then you guys will probably remember our famous Ishikawa, or the fishbone. This is a very, very busy slide, but a couple of the key things on this slide, not to bore you, is what are we trying to do? This is the head of the fish. We're going to get hypertension to goal. What we do that's a lot different, if you look back to what Bob had mentioned, a lot of folks will come up with one great idea and they'll roll with that, and another great idea and roll with that. One thing that we learned through quality theory is you don't come up with one or two great ideas, you get everything on the table. And we broke this into 6 different areas. So we basically put staff up here and figure out, okay, what can the staff do to help us with hypertension? We then go over here and look at policies and procedures within the office. What can we do? What are all the different variables that are going to be involved in that particular area? The third big area is the internal environment. What systems do we have in place, EHR, software packages, etc.? Which one of those can we use? And there's a whole bunch that are listed in through here. As physicians, what are we going to be asked to do? What can we do? Then we get down to patients. What do we need them to do? Healthcare environment. Simple things like, does your insurance cover your medications? Do you have insurance in general? All these get listed. Now, you could pick any one of these and begin to work on it, but some of these you could put a tremendous amount of time, a tremendous amount of effort into it, and get a very small incremental piece. So part of our hypertension task force, which I was not part of, a lot of guys in this room, a lot of women in this room got together and said, okay, let's look at all these variables. What's the low-hanging fruit? What can we do that will make a big difference in a quick way? And in this particular slide, you can see in red is the areas that they picked. They thought this is probably what we can do to make the biggest bang for the buck. So this is pretty much what we had decided to do. So we've got our fishbone, we've got our Ishikawa. Then we basically begin to create the true process. A couple of the big things within the process, if you go back, is addressing hypertension at every single visit turned out to be huge. So if you have a sore ankle, you have a sore throat, we're going to address hypertension. This is actually a little bit new to adult medicine, but if you go back to pediatrics, what do they do with immunizations? It's called missed opportunities. If they come in for some other problem, they're looking at their immunizations, oh my gosh, you missed it, they got them up to date. That is something not foreign to them. They do it on a routine basis. To us, that's a bit foreign. You come in with a sprained knee and I'm going to address your hypertension. Well, we all agreed to go ahead and do that. So that was one of the big things that was put into that. The next one is our impedance cardiography, the Bio-Z. This was a new tool. It seemed to make sense. We know what the standard of care had gotten us. It got us 40%. What everybody else had been doing basically kept getting us 40%. So we decided, let's go ahead and see what this particular tool does, and we decided to use this also, which is a little bit out of the norm. The other big one was basically drug selection. We started looking at the drugs, organizing them. If you remember on our hypertension flow sheet, we have the JNC7 guidelines. Let's follow those closely and use those particular areas. And also push the drugs up to what we need. Instead of basically adding 2, 3, and 4, we would bump those up. But we really have a pretty good process on how we use our hypertension drugs. And you probably remember the very first version. This is the Peacock. Very, very busy. There's a ton in here, but this was our first version of this slide. When you look at quality theory and you're doing processes, the first process usually is not the final process. So we got to a certain level of success and someone said, you know what, we probably need a little bit better process. So we actually refined this. This is the one that you're going to see, which is much more familiar to all of us. So this is what we ended up coming up with. Typically, for those who aren't familiar, we'll explain this in a little bit more detail. I will not belabor that today. So now, as we go through this, we've come down through these 4 particular steps. And whenever we do have any processes, just like in any other industry, we're going to have areas in time where we're going to have different questions. Does it work? Does it not work? One of the things we do in quality theory isn't a feeling, it isn't a passion. We measure things. We use statistics to help us make decisions. Is it helping? Is it not helping? So one of our commitments is to follow statistics.